Hello, my name is Eric HACHULLA. I'm working at the University of Lille. In 2022, we published the new recommendations for the diagnosis and management of pulmonary arterial hypertension by the European Society of Cardiology and Pneumology. But what does that change in practice for scleroderma patients? We'll see two parts. First, diagnosis and screening, and thereafter, with Professor Olivier and SITBON, the treatment aspects. Connective tissue diseases are still in the group 1 of pulmonary hypertension. But we have to keep in mind that in scleroderma patients, this is more complicated. It can be also a portopulmonar hypertension, still group 1, can be with a veno-occlusive component, still group 1, can also be a group 2 with heart failure, particularly diastolic dysfunction, can also be related to lung fibrosis, it's a group 3, or sometimes a group 4 due to chronic thromboembolisms, particularly in patients with antiphospholipid syndrome. Right heart cath is still the gold standard for the diagnosis of pulmonary hypertension. It's an hemodynamic definition. The new definition, it's mean PAP above 20. It means from 21 mm mercury, with pulmonary vascular resistance above 2 Wood unit. And if the pulmonary arterial wedge pressure is less than 15, it's a precapillary pulmonary hypertension. Echocardiography remains the best screening tool based on the tricuspid jet velocity. And 2.8 meters per second for the tricuspid jet velocity is a cutoff where you have to think about the possibility of pulmonary hypertension in a scleroderma patient. If it's above 2.8, scleroderma patients are at high risk of pulmonary hypertension, and if there are other signs associated to the tricuspid jet velocity showing a risk of pulmonary hypertension, right heart cath should be performed. What are the other signs of pulmonary hypertension on the echocardiography? Particularly 3 very important. First of all, the right atrial area. If it's above 18 centimeters square, you have to think to the possibility of pulmonary hypertension. If the pulmonary acceleration time is lower than 105 meters per second, you have to think about the possibility of pulmonary hypertension. It's also the case in case of TAPSE systolic PAP ratio. If this ratio is lower than 0.55, it's a risk of pulmonary hypertension, and you have to discuss the realization of a right heart cath. What are now the recommendations for the screening of PAH in scleroderma patients? In patients with scleroderma, a yearly evaluation should be performed. Using the DETECT algorithm, in case of scleroderma evolving more than 3 years, in case of DLCO lower than 60% and FVC above 40%. In that case, use the algorithm, the DETECT algorithm. In the other cases, you can use a pulmonary functional test, you can use a NT-proBNP level in the blood. And sometimes, but it's not available in all centers, you can use the exercise echo, you can use cardiopulmonary exercise testing or the cardiac MRI, but it's not routinely performed. Focus on mean PAP 21-24 mm mercury. This is a particular population of interest. based on the U-star population. This was showing at the last ACR in Philadelphia in 2022, in November. Out of this U-star registry, 422 patients had right heart cath. And you can see on the right that 80 out of them had a mean PAP between 21 and 24. And what is very interesting in that population is that based on the echo, you cannot suspect pulmonary hypertension. The right area is normal, and the ratio TAP-say systolic PAP is also normal. And despite that, the 3-year mortality is 12%. So we have to identify, we have to detect this population. How can we detect this patient at risk, this patient having pulmonary hypertension based on the new definition? We have the DETECT algorithm. You know that the DETECT algorithm was performed in a population with 3 years and more evolution of scleroderma, with a DLCO less than 60%, and with the old definition of pulmonary hypertension. It means mean PAP 25. And we use in that DETECT algorithm some pulmonary functional test data, some clinical data, some echocardiography data with a step 1 and a step 2. In our department, we perform a DETECT algorithm in all patients yearly, but both steps. Step 1 with before the echo, and step 2 systematically with the echocardiography. And you have a score, a final score. Here, in that example, a score of 37. The patient is at risk, but at a low risk of pulmonary hypertension. This introduces a discussion of performing or not a right heart cath discussion with your cardiologist and pneumologist. Can the DETECT algorithm identify patients with 21-24 millimeter mercury? The answer is yes. We have worked the last months with Olivier going back to all the population of the DETECT study, and we have shown that applying to the DETECT algorithm the detection of patients with mean PAP above 20 and a PVR above 2, the sensitivity of the test is really good, of 87%, and specificity is 50%. So quite the same as the detection with the old definition. So the DETECT algorithm can identify patients with 21 to 24 millimeter mercury. In all cases, when you have performed the diagnosis based on the right heart cath of a pulmonary hypertension, it means mean PAP 21 or more, you have to discuss if it's really a group 1, because only the group 1 needs a specific treatment for pulmonary arterial hypertension. Keep in mind that this can be also portopulmonary hypertension, can be also with a veno-occlusive component, but all these 3 cases are group 1, with the treatment of specific pulmonary arterial treatment. But this can also be a group 2, so check if there is diastolic dysfunction. This can also be a group 3. Is there a severe lung fibrosis? In that case, probably it's a group 3. In that situation, it's more the treatment of the lung fibrosis that you have to propose. And sometimes it's a group 4 with thromboembolic mechanisms. So you have to always have angiopulmonary arteriography to be sure there's no chronic thromboembolism. In all cases, it's a multidisciplinary approach with your cardiologist, your pneumologist, your radiologist to well classify the patient and to discuss the treatment. And the treatment is actually exactly the same as idiopathic pulmonary arterial hypertension. And this will be discussed by Professor Olivier SITBON. But last, not least, patient education is now recommended in the last recommendation. Patient education, it's not information. don't think it's the same. Patient education, it's a tailored information given to the patient based on small workshops, sometimes with other patients, with the objective to improve the knowledge of the disease and to give your patient a better quality of life. Thank you for your attention.
Hello, I'm Olivier SITBON. I'm professor of respiratory medicine at the French Referral Center for Pulmonary Hypertension in Université Paris-Saclay in Le Kremlin-Bicêtre. And now I will discuss the therapeutic aspects of the ESC ERS guidelines for the diagnostic and management of PAH and what does it change in practice for scleroderma patients. That's my disclosures. Here is the treatment algorithm we use for the management of patients with pulmonary arterial hypertension. And if we want to focus on patients with systemic sclerosis, the first recommendation is to consider the treatment of the underlying conditions according to the guidelines, and this is the first recommendation. Then, in patients with PAH associated with connective tissue disease, and in particular in scleroderma, which is the most important number of patients in this subgroup of patients, the same treatment algorithm as for patients with IPAH is recommended. After considering the general measures like diuretics, like oxygen if needed, we have to look at the risk and we have to assess the risk and then to consider the initial therapy. We initially separated patients without comorbidities and patients with comorbidities. If we start with the patient without comorbidities, the first step is to consider the risk. But I just want to also give an information about anticoagulation. Anticoagulation is not generally recommended in patients with PAH, not only in patients with scleroderma, but in all forms of PAH. And this may be considered as an individual basis. And as you can see here, the class of recommendation is only 2B. So let's move now to the risk, and for the risk assessment we use the 3 strata model, and you know this very famous table from the previous guidelines, and there are some new information in that table. In particular, we added information on MRI. We also had some other parameters on echo or also on hemodynamics, and we changed a bit the threshold of BNP or NT-proBNP. But the philosophy it is the same. We have 3 strata: low risk, intermediate risk, high risk, and for each variable we attribute 1 point for each variable in the green zone, 2 points in each variable in the intermediate zone, and 3 points for each variable in the red zone. And we divided the sum by the number of available variables. And with this, we can assess accurately the risk of death at 1 year. So according to this, after this assessment, and according to this assessment, we have to consider initial therapy for the patient at high risk. The high risk of death is more than 20% mortality at 1 year. In those patients, we have to give triple combination therapy, including IV or sub-Q prostacyclin. It is well demonstrated in patients with heritable or idiopathic PAH. The information in patients with scleroderma is we have much less information for those patients, but we can apply also this algorithm. And for the vast majority of the patients, we have to consider initial double oral combination therapy with an endothelin receptor antagonist and a PDE5 inhibitor. And this has been clearly showed in the Ambition trial, comparing two strategies, initial combination of ambrisentan and tadalafil compared to monotherapy. And we know that the combination therapy reduced the risk of clinical failure in PAH and also in particular in PAH associated with connective tissue disease and in PAH associated with systemic sclerosis, and the change in the reduction of the risk is the same in that population as compared to the entire population enrolled in this trial. Then, after considering the initial therapy, we have to reassess the risk, and we have a new approach to reassess the risk. We have a simpler approach using not the 3 strata model, but a 4 strata model using 3 non-invasive variables: functional class, 6-minute walk distance, and BNP or NT-proBNP. And we can categorize the patient as low risk, intermediate low, intermediate high, or high risk, with the same approach for the calculation that we did for the before initial therapy. And the only treatment goal is to achieve a low risk profile, which is very, very important. And we showed in the French registry, when we validate this method that was developed by the Compera investigators, that we showed in the French registry that it is applicable in PAH, but also in the different forms of PAH, in connective tissue disease and in scleroderma, with an excellent granularity in between the different survival curves. So, for the patient at low risk, we have to continue with the same therapy, and we have to continue to follow up those patients every 6 months, usually. For the patient at intermediate high or high risk, we have to escalate the therapy with a very demanding treatment, which is subcutaneous or IV procyclin, and we also have to consider lung transplantation for eligible patients. For the majority of other patients at intermediate low risk, we have the choice in between adding a prostacyclin receptor agonist, selexipag, or to switch from PDE5 inhibitor to soluble guanylate cyclase stimulator, riociguat. However, the evidence for this approach is less good than for adding a third drug. And if you look at the sequential combination therapy trials, we can see that the effects observed in patients with connective tissue disease is very, very consistent as what we observed in the overall PAH patient population. It is true in Seraphine, in Griffin, in Freedom, in other trials using morbid mortality as a primary endpoint. Now we move to the patient with comorbidities. For the patient with comorbidities, that means that patient having an increased risk of heart failure, of left heart failure, in particular diastolic dysfunction. That's patient with diabetes, hypertension, obesity, coronary heart disease, or patient with pulmonary comorbidities with a very low DLCO. It's probably more difficult to interpret in patients with scleroderma. But in those patients, the recommendation is to initiate monotherapy, either PDE5 inhibitor or endothelin receptor antagonist, and to consider the treatment escalation on an individual basis. So the recommendation is probably to see the patients not too late after initial therapy, maybe 3 months, 4 months after initial therapy, in order to escalate if needed. What about the patient having interstitial lung disease? We know that those patients may be seen in patients with scleroderma, and we know that the survival in those patients having both pulmonary hypertension and interstitial lung disease, the survival is poorer than patients having just PAH in scleroderma. And we also know that the deterioration in gas exchange on therapy, which is quite often observed in those patients, is a major prognostic factor. However, we have recently the data of the increased trial of inhaled treprostinil, a prostacyclin analog in PAH due to interstitial lung disease. And in that study, that included 72 patients with connective tissue disease, representing 22% of the population enrolled in that trial. That trial showed that a significant improvement in 6-minute walk distance in patients on active drugs as compared to patients on placebo. And also, we know that there was also a significant change in NT-proBNP and on the number of clinical worsening events. In patients with scleroderma, we know that they can have pulmonary vein involvement. We can call that PVOD-like. And we know that those patients have a very, very poor survival as compared to patients who do not have pulmonary vein involvement. And we have to be very cautious with that, and we have to look at the CT of those patients to seek for typical signs of PVOD, like ground glass opacities or septal line thickening. What about immunosuppressive therapy? We know that immunosuppressive therapy is usually not efficacious in PAH associated with scleroderma. However, there is a recent trial with rituximab showing a trend for a potential efficacy of rituximab as compared to placebo in patients with PAH and in the context of scleroderma. After 24 weeks, there was no significant difference, as you can see here, but there was a trend. And after 48 weeks, it was significant, and this was seen in parallel with a depletion in B lymphocytes. What about the new potential targets and the new novel treatment targets in PAH? There are many targets and many drugs. There are also a lot of randomized phase 2 trials that were negative. However, there are some hope with some approach, in particular the BMPR2 activin pathway and the PDGF pathway and maybe the serotonin pathway. And now we have the data from the sotatercept study, the PULSAR study, which was a phase 2 study. And the sotatercept is an interesting treatment. It acts by rebalancing the signaling between the pro and the anti-proliferative pathways. And when we give sotatercept subcutaneously every 3 weeks in patients with PAH, in that study there are 17% of patients with connective tissue disease, we observed that a significant decrease in pulmonary vascular resistance, which was the primary endpoint, but we also observed significant improvement in key secondary endpoints like 6-minute walk distance, NT-proBNP, and functional class. So it is really a promising drug in the PAH therapy. What about lung transplantation? We know that transplantation is usually, we know that scleroderma is usually a contraindication for lung transplantation. But if we select the patients, if we can highly selected patients, I think we can consider lung transplantation in those patients if they are young, if they don't have a specific contraindication as it is listed here. So I would like to finish with my take-home message. First of all, in patients with PAH associated with connective tissue disease, and in particular with scleroderma, the same treatment algorithm as for patients with IPAH is recommended. We know that the PAH therapies are usually less efficacious in those patients than in IPAH because of comorbidities, of ILD, of post-capillary involvement. The use of available PAH therapies can be associated with an increased risk of gas exchange worsening in patients with ILD. And finally, indications for lung transplantation are limited, of course, but it could be possible in highly selected patients. Thank you very much.